Hello friends. So today we'll be discussing the drugs acting on renin-angiotensin-aldosterone system, otherwise known as the Raas system. Okay. So this is very important because we have many drugs that acts on this system, the Raas system. So what is this Raas system or renin-angiotensin-aldosterone system? Okay. So we know that angiotensinogen is converted into angiotensin 1 with the help of renin, okay, which is secreted from the JG cells, juxtaglomerular cells, whenever there is hypovolemia or when the beta receptors are stimulated, it will help in release of this renin that will convert angiotensinogen to angiotensin 1. This angiotensin 1 is converted into angiotensin 2 with the help of ACE, otherwise known as angiotensin converting enzyme. Angiotensin converting enzyme. Okay. And what does this angiotensin ACE do? What does this angiotensin 2 do? It goes and acts on angiotensin receptor, that is AT1 and AT2, mainly AT1, and that brings about the actions. After its action is over, the angiotensin gets converted by aminopeptidases to angiotensin 3 and then finally undergoes degradation. Now, where does these drugs acting on this Raas system act? It can act on each of these steps, right from renin release inhibitor. You have beta blockers which inhibit the release of renin. Then you have agents that directly inhibit the renin, that is your aliskiren group of drugs. Then you have drugs that inhibit the conversion of angiotensin 1 to angiotensin 2, that is your AC inhibitors. Then you have drugs that directly inhibit at the level of receptor, that is your angiotensin receptor blockers. Now we'll see what is the action of angiotensin 2, because of which we need all these drugs to block the system. So we'll see what is the renal response to decreased blood pressure. So when the blood pressure falls, as I told earlier, the juxtaglomerular cells secretes renin. Okay. And what does this renin do? The renin converts angiotensinogen to angiotensin 1 that converts angiotensin 1 is converted into angiotensin 2 with the help of angiotensin converting enzyme or the ACE. What does this angiotensin 2 do? Angiotensin 2 has got two actions. One is it stimulates the adrenal medulla to secrete adrenaline that will cause vasoconstriction. That is the direct effect of angiotensin 2. Okay, angiotensin 2 causes vasoconstriction and increases the BP. Second action of angiotensin 2 is it causes the secretion of aldosterone from the adrenal cortex. And what does this aldosterone do? And aldosterone is a mineralocorticoid that will cause salt and water retention, and it is involved in cardiac remodeling. So because of the salt and water retention, also the BP rises. So these are the two mechanisms, basically the body's feedback mechanism. When the BP falls, the renin is released. That will cause increased production of angiotensin 2. That will cause direct vasoconstriction plus release of aldosterone, which in turn causes sodium and water retention and increases the BP. Okay. So there is direct vasoconstriction as well as stimulation of aldosterone synthesis. So angiotensin 2 is a potent vasoconstrictor, plus it stimulates the release of aldosterone from the adrenal cortex, that will increase the sodium and water retention. These two actions are there. Plus it is a growth factor. Angiotensin 2 is a growth factor for vascular smooth muscles and myocardial cell, which has a role in ventricular remodeling and also influences the noradrenaline release from the sympathetic nerve terminals, because of which, because of this effect on this ventricular remodeling, this drugs acting on Raas system has got an important role in congestive cardiac failure as well as in severe chronic hypertension to prevent the ventricular remodeling, and that helps in decreasing the morbidity and mortality associated with these disease conditions. So this is one of the drugs that improves survival in cardiac failure patients. Which are the drugs that act on Raas system? We have seen earlier. Drugs which inhibit the renin release, we have beta blockers, sympatholytic agents like clonidine, alpha methyl dopa, which are central uh, sympatholytic agents. Then we have direct renin inhibitors like aliskiren, remiskiren, angiotensin converting enzyme inhibitors or ACE inhibitors. We have everything ending with pril, that is enalapril, laptopril, lisinopril, ramipril. Then you have angiotensin receptor blockers, that is your sartans, losartan, telmisartan, candesartan, irbesartan, aldosterone antagonists like spironolactone and eplerenone. So these are the drugs that act on Raas system. So we'll see ACE inhibitors or angiotensin converting enzyme inhibitors. What does it do? It inhibits a conversion of angiotensin 1 to angiotensin 2. Okay. So this is inhibited by ACE inhibitors. At the same time, when this step is inhibited, this level is the bradykinin level also increases, because the bradykinin metabolism to its inactive metabolite is also by this ACE. When that is inhibited, the bradykinin level increases. So bradykinin is also a potent vasodilator that also helps in this decreasing BP effect of ACE inhibitors. But what is the problem? When bradykinin increases, that is the reason why the patient can have different allergic manifestations like angioedema, dry cough, all are manifestations of bradykinin level increase. So ACE inhibitors inhibits the formation of angiotensin 2 and thereby decreases the BP both by direct as well as indirectly by inhibiting the aldosterone release. Plus, it raises bradykinin, which is a potent vasodilator. In addition, it decreases the noradrenaline levels and reduces the sympathetic activity and inhibition of this aldosterone secretion, because of which it has a role in ventricular remodeling also. Which are the drugs? Captopril, enalapril, lisinopril. At least remember 4 drugs. How do we give it? The important pharmacokinetics. We give it orally. All of these agents are prodrugs except captopril and lisinopril. So they're getting activated in the body. They're excreted through kidney. So you require dose reduction in severe renal failure. Short acting ones is captopril, which is the shortest acting. Intermediate acting we have enalapril, and then long acting we have perindopril, lisinopril and ramipril. The longest is perindopril. Okay. What are the therapeutic uses where we need to decrease the blood pressure? That is your hypertension. So it is useful for all grades of hypertension, often combined with a diuretic, because when you're using a diuretic, what is happening? The salt and water is excreted from the body. As a result, renin levels are increased. So ACE inhibitors have got a more potent role when you're using it with a diuretic. Then left ventricular hypertrophy can be reversed. So especially if there is left ventricular changes in a patient with hypertension, always start on ACE inhibitors. Effective in many patients with low renin as well as high renin hypertension. So the next main use of ACE inhibitors is congestive cardiac failure. As I told earlier, one is immediate effect. ACE inhibitors, it causes vasodilatation, both arteriolar and venodilator. So it decreases both preload as well as afterload. Preload is dependent on the venodilatation. Okay, the venous return decreases, so preload decreases. Afterload is based on the total peripheral resistance. So by vasodilatation, both preload and afterload is reduced. Long term, as I told, since it inhibits the action of aldosterone and thereby the ventricular remodeling, this is one agent that has shown to improve survival in CCF patients. So AC inhibitors, ARBs, beta blockers, aldosterone antagonists. These are the 4 group of drugs that are shown to improve survival in CCF patients. Okay. Then in myocardial infarction also, it is found to decrease mortality. So we give it if the patient has associated heart failure, okay, or patients who are at high risk of cardiovascular events. Then another indication for AC inhibitors is diabetic nephropathy or chronic renal failure, because usually the starting of albuminuria or diabetic nephropathy, we can detect it early by checking the microalbumin level. So if there is microalbuminuria and then you start AC inhibitors, it is shown to delay the progression of diabetic nephropathy. Or if you start earlier, if the patient is diabetic and is found to be hypertensive, if you start him on AC inhibitors, it is found to delay the onset of diabetic nephropathy. So it delays the progression or prevents the occurrence of albuminuria and nephropathy. So initially when you start a patient on AC inhibitors, prior to that you should check the RFT levels, renal function test, because the serum creatinine can increase up to 30% within the first 2 to 5 days, okay, after starting the treatment, but it stabilizes in 2 to 3 weeks and then it comes down and it is reversible on stopping. If it is more than 30% increase, then we have to reduce the dose or we may have to think about stopping AC inhibitors. Up to 30% it is considered okay. And another use is scleroderma renal crisis. So the important use you should remember: hypertension, especially both with high renin as well as low renin, then congestive cardiac failure, diabetic nephropathy. These are the important uses. Then in myocardial infarction are those with increased risk of cardiovascular events, and scleroderma crisis are the other uses of AC inhibitors. Now, what are the adverse effects of AC inhibitors? It can cause dry cough, urticaria, angineurotic edema, which is seen in 0.1%, and all these are due to increased bradykinin levels. As I told earlier, AC inhibitors not only inhibits the conversion of angiotensin 1 to angiotensin 2, but also inhibits the conversion of bradykinin to its inactive metabolite. So levels of bradykinin increases, that leads to vasodilation, plus these side effects will be there. Other side effects, since it causes dilatation, it can cause hypotension. Start with a small dose. Hyperkalemia, again a very important side effect that you should remember, because especially if you start the patient on potassium sparing diuretics like spironolactone, amyloid, etc., or if the patient has concomitant renal failure, then there is more chance of patient going in for hyperkalemia. So always remember, AC inhibitors, important side effect is hyperkalemia. So if you give it with other potassium sparing diuretics, it can potentiate the potassium levels and that can lead to arrhythmias, ECG variations. Okay, hyperkalemia is manifested as tall T waves in ECG. Then acute renal failure in patients with bilateral renal artery stenosis, or if a patient has a single kidney and that kidney has got renal artery stenosis, then also it is contraindicated. It is a teratogenic drug. It can cause growth restrictions, malformed lungs, because of which it is contraindicated in pregnancy, and dysgeusia, that is alteration in taste sensation. So remember, always remember, AC inhibitors, dry cough, angioedema because of bradykinin levels. One more thing, if the patient, it is an excellent drug. So you start them on in April. Patient has this dry cough which is very irritating, which is impairing his quality of life. What you can do? You can stop AC inhibitors and start him on ARBs. We'll see in the coming slides why ARBs do not have the side effect, but AC inhibitors have, because of increase in bradykinin levels. Then hyperkalemia, acute renal failure and bilateral renal artery stenosis, teratogenicity, dysgeusia. So most of the things regarding AC inhibitors you can remember using this mnemonic: captopril. Captopril you can think as a prodrug or prototype drug of AC inhibitor. So cough is a side effect, angioedema, all these are prodrugs, can cause taste disturbances, hypotension, especially you combine it with diuretics. Pregnancy is a contraindication. Bilateral renal artery stenosis is a contraindication, hyperkalemia, and lowers the formation of angiotensin II. That is a mechanism of action. Okay. So next we come to the therapeutic combinations. You can combine it with diuretic. It is actually a very good combination. Why? Two reasons are there. Diuretics causes sodium and water loss. So renin levels are increased. That can be compensated by giving a AC inhibitor. Plus, diuretics like furosemide or thiazides causes hypokalemia, whereas ACE inhibitors causes hyperkalemia. So the potassium levels remain normal. So there is additive antihypertensive effect plus reduce the thiazide-induced hypokalemia. Adverse interaction is, as I told earlier, you should not combine it with a potassium-sparing diuretic because it can cause severe hyperkalemia. With NSAIDs also, the renal damage is more. So next we come to ARBs or angiotensin receptor blockers. These are all sartans. They end with sartan, losartan, valsartan, olmesartan, telmisartan, azilsartan, eposartan. So at least 2 or 3 you should remember. How does it act? You've seen angiotensin 2, they come and act on AT1 receptor and AT2 receptor. So these directly block the angiotensin 2 at the AT1 receptor site, competitive inhibitor at AT1 site. And most of the effects of angiotensin 2 are mediated by AT1 receptors. So the same action, the angiotensin 2 actions are blocked. As a result, there will be vasodilatation plus there will be decreased aldosterone secretion. As a result, salt and water retention is not happening. What is the advantage over ACE inhibitors? Since it is directly targeting the receptor AT1, there is no interference with the bradykinin metabolism. The bradykinin levels are not increased. Therefore, there is no dry cough or no angioedema. That's a major advantage. Adverse effects, it can cause hypotension, hyperkalemia. It is also teratogenase effect like ACE inhibitors. But the dry cough, angioedema, and other allergic reactions are less with ARBs because the bradykinin levels are not interfered with. Uses same as that of ACE inhibitors. We use it for hypertension, cardiac failure, myocardial infarction, and diabetic nephropathy. Now coming to the direct renin inhibitor, that is aliskiren, reniskiren. It competitively blocks the renin and decreases the BP. Orally active, usually in severe hypertension, you use it as a combination therapy to combine it with other drugs. These are the other drugs in the group, enalakiren and remikiren. So with that, we finish the drugs acting on Raas system. So we have discussed mainly on ACE inhibitors, ARBs, and direct renin inhibitors. The other drugs, that is those which inhibit the renin release, that is your beta blockers, clonidine, alpha methyl dopa, we have discussed earlier. And the last group, that is aldosterone antagonists, that is spironolactone, eplerenone, we'll cover more in detail in your diuretic chapter. Okay. So also we'll cover that in heart failure also. Okay. So that is regarding the drugs acting on Raas system. ACE inhibitors, very, very important mechanism by inhibiting angiotensin 2, thereby direct vasodilatation and indirectly by inhibiting aldosterone secretion. What are the main uses? Hypertension, CCF, diabetic nephropathy, three main uses. Adverse effects, remember because of bradykinin level, dry cough, angioedema, hyperkalemia, and higher dysgeusia and teratogenic effects. Contraindications, bilateral renal artery stenosis and teratogenicity. Advantage over ARBs, over ACE inhibitors is there is no dry cough. Indications, adverse effects almost same, except the dry cough angioedema part is not there for ARBs. And direct renin inhibitors, examples you should know, aliskiren, remiskiren, etc. Direct inhibitor usually as an add-on for severe hypertension. Okay. So hope that is clear. Thank you for listening.